Bismillah ar-Rahman ar-Rahim. Hemolytic uremic syndrome, HUS. Hemolytic uremic syndrome is one of the most common causes of community-acquired acute kidney failure in young children. It is characterized by the triad of microangiopathic hemolytic anemia, thrombocytopenia, and renal insufficiency. Hemolytic uremic syndrome has clinical features in common with thrombotic thrombocytopenia purpura, which can include also CNS involvement and fever, with more gradual onset. Most cases of hemolytic uremic syndrome, but few cases of thrombotic thrombocytopenia purpura occur after an acute gastrointestinal illness, which is usually diarrheal. Etiology. The various etiologies of hemolytic uremic syndrome allows classification into 1. Infection-induced. The most common form of hemolytic uremic syndrome is caused by toxin-producing E. coli that cause prodromal acute enteritis and is commonly termed diarrhea-associated hemolytic uremic syndrome. In the subcontinent of Asia and Southern Africa, the Shiga toxin of Shigella dysentery type 1 is causative, whereas in Western countries, virotoxin-producing E. coli, VTEC, are the usual cause. Several serotypes of E. coli can produce virotoxin, and the O1572A7 type is most common in Europe and the Americas. The reservoir of VTEC is the intestinal tract of domestic animals, usually cows. Disease is usually transmitted by undercooked meat or unpasteurized milk or apple cider. Hemolytic uremic syndrome outbreaks have also been associated with municipal water supply, petting farms, swimming in contaminated pools, and consuming cheese, lettuce, or raw spinach contaminated with toxin. Less often, hemolytic uremic syndrome may spread by person-to-person contact within families or child care centers. A rare but distinct form of hemolytic uremic syndrome is related to neuroaminidase producing streptococcal pneumonia, which is typically presented with pneumonia and empyema, and thrombotic microangiopathy similar to hemolytic uremic syndrome, and TTP also occurs in untreated HIV infection. 2. Genetic causes. Second major category, mostly without preceding diarrhea prodrome, can be indolent and unremitting or have a relapsing pattern precipitated by infections. 3. Medication-induced, like cyclosporine, tacrolimus, chemotherapy, as mitomycin C and splatinum, clopidogrel and ticlopidine and quinine. The last cause is hemolytic uremic syndrome associated with systemic diseases characterized by microvascular injury as malignant hypertension, SLE, antiphospholipid syndrome, following bone marrow or solid organ transplantation. Clinical presentation. The onset is abrupt with manifestation of 1. Microangiopathic hemolytic anemia as intense pallor. The examination of blood smear is important to identify RBC fragment, Burr cell, and schistocytes, as well as severe anemia and reticulocytosis. 2. Acute renal failure, which is usually but not always oligoanuric, with acidotic breathing and altered consciousness, by increasing blood urea, increasing serum creatinine, increasing serum potassium, and metabolic acidosis. 3. Thrombocytopenic purpura, which may be mild, that is, platelet count is about 120,000 per cubic millimeter, to severe when platelet count less than 20,000 per cubic millimeter. Pathogenesis. The primary event is the endothelial cell injury. Capillary and arterial endothelial injury in the kidney lead to localized clotting. The microangiopathic hemolytic anemia results from mechanical damage of RBC as they pass through the altered vasculature. Thrombocytopenia is caused by intrarenal platelet adhesion or damage. Complications include anemia, acidosis, hyperkalemia, fluid overload, heart failure, hypertension, uremia. Extrarenal manifestations include CNS, irritability, seizure and coma, GIT, colitis, intestinal perforation, intussusception, and hepatitis. 3. Heart complications including pericarditis, myocardial dysfunction, and arrhythmias. 4. Other rare complications as focal pancreatic necrosis, skin necrosis, parotitis, and adrenal dysfunction. Prognosis and treatment. The acute prognosis with careful supportive care for diarrhea-associated hemolytic uremic syndrome has less than 5% mortality. Half of the patients require dialysis support during the acute phase of the disease. Most recover renal function completely, but of surviving patient, 5% remain dependent on dialysis, and up to 20 to 30% are left with some level of chronic renal insufficiency. The prognosis of hemolytic uremic syndrome not associated with diarrhea is more severe. Pneumococcal associated hemolytic uremic syndrome causes increased morbidity with 20% mortality. The familial genetic form of hemolytic uremic syndrome can be insidiously progressive or relapsing disease with poor prognosis. Identification of specific factor deficiencies in some of this genetic form provide opportunity for specific replacement therapy to improve outcome. The primary approach for hemolytic uremic syndrome include early recognition of the disease, monitoring for potential complications, and meticulous supportive care as fluid and electrolyte balance, control of hypertension, early institution of dialysis if the patient becomes anuric or significantly oliguric, and RBC transfusion. Platelets should generally not administered regardless of platelet count because they are almost immediately consumed by the active coagulation. Despite low platelet count, serious bleeding is very rare. Anticoagulation, antiplatelet, and fibrinolytic therapy is contraindicated because they increase the risk of serious hemorrhage. Antibiotic therapy to clear the toxigenic organism can result in increased toxin release and therefore not recommended. Prompt treatment of any underlying pneumococcal infection is important. Binders of viro or Shiga toxin in the gut are unsuccessful. Plasma infusion or plasmapheresis has been proposed for patients suffering severe manifestation of hemolytic uremic syndrome, primary serious CNS involvement, specifically genetic hemolytic uremic syndrome. Most patients with diarrhea-associated acquired hemolytic uremic syndrome recover completely with little risk of long-term sequelae. However, patients with hypertension, any level of renal insufficiency, or residual urinary abnormalities persistence a year after the episode of diarrhea-positive hemolytic uremic syndrome require careful follow-up. شكرا جزيلا لحسن استماعكم.